Hey guys, it's Charles Beasley and welcome to Good Clinical, a podcast and YouTube channel dedicated to showcasing the future of medicine and human health. Today's episode is another in our partnership with Te Titoki Mataora, an industry body supporting the commercialization of great ideas in medical technology. Today's guest is Dr Caz Hales. Caz is the school director at the University of Victoria, Wellington, and here to talk about her project that she is partnering with Te Titoki Mataora. Caz, great to have you on the podcast today.
Thank you. Thank you for having me.
Absolutely. So you are a registered nurse. That's your background. You've spent a long time in particularly in the intensive care unit setting as a registered nurse. Why don't you provide a little bit of background about your career and experiences and your perhaps the moment that triggered a pivot for you into your current discipline, which is working with people living with obesity?
Yeah. Okay. Yeah. Thank you. So, why did I become a nurse? That's a question that lots of people kind of ask, and that's a really difficult one to kind of really put your finger onto. What was that defining moment, I suppose? And I think that I spent a lot of time as a child in hospital, and it was a time in the 80s where parents didn't stay in hospital with you, and so you were cared for by the nurses, and so the nursing team were the people that looked after you. Your parents went home and came and visited, and so that was a really informing time for me about how nurses provided that kind of care. And so I experienced really loving care and care that was I was frightened of some of the nurses and that kind of thing. And so that was quite gave me a lot of interest into, well, what are the experiences of people and patients when they come into sort of hospital? And when I was 16, I went back into hospital, and there was a nurse there who had cared for me when I was 4 and 5 and 6. And I had this moment of feeling really secure and safe, because she'd been such a kind and caring nurse. And that really kind of triggered my interest in being a nurse, and knowing that there were those experiences are really, really important when people come into hospital. And so then when I was 18, I went to university and enrolled in a Bachelor's of Nursing and Honours degree, which was really new at the time. They were, I think, the second or third year that they were being offered, and off I went and I trained to be a nurse. And that was kind of the beginning of my nursing career. Yeah.
Wow. Do you mind if I ask, what were you in hospital for when you were at the ripe old age of 4?
Oh,
and then
yeah.
back again at 16? Gosh.
Yeah, so really interesting. I have a rare bone disorder called symphalangelism, which affects just your hands and feet. And it just means that I don't have some joints in my fingers and toes, and also have some webbing called symphalangelism. And so they were just surgical procedures that I was required to have done, and it was done periodically. I had 5 or 6 procedures, and so I went into hospital and was cared for as part of a surgical teams, and so those sort of things kind of, it just was what happened to me, really. But those experiences really kind of informed my nursing career, really.
Yeah, I can imagine. I mean, being that young and parents kind of dropping you off and leaving you for a day or so, and then coming back to pick you up once you're all stitched back up. Different world, right?
Absolutely. Whereas now it's completely changed. And so they were in a different city. They'd come and see me each day for visiting hours, and they'd go home. And so the nurses provided care. I was in a school hospital, and I was only there for like 7 days at a time. But when you're 4, 7 days is a long time. A long time.
Wow.
And so really that has significantly informed my interest in understanding patient experiences and how feeling safe, feeling secure, really important aspects of being in hospital.
Absolutely.
Yeah.
And is that why you decided to spend the most of your career in an intensive care setting? Because that is a very frightening place to be, very high level requirements. I can imagine, fortunately, I've never been in intensive care myself, but having a good nurse.
Interestingly, no, it wasn't really.
Oh,
So when I went into my training, I wanted to be an emergency nurse, and we had a choice of being either an ED nurse in a placement or going into ICU. And I always loved everything I did in nursing, and because I knew I wanted to be an ED nurse, I thought, well, I'll never ever go into an intensive care unit. So for my placement, I'll go and work in intensive care. So then I've experienced what it's like to be in intensive care. And I went and I loved it. And that was the beginning of my intensive care career. And I have never worked in ED. And so it was doing something that I thought that I would never do, that I went and
yeah,
did, that became my career. However, I think that the technology in ICU, and that most people think that being in ICU is about technology, about the kind of drive of the precision of the intensive care environment. But actually, my experience is much more about that humanistic, applying that humanistic touch and being with people in that very, very vulnerable moment of being in intensive care. Again, that patient experience, being with people, that's really, really important about that, that intensive care environment. Yeah.
right. So is that awareness of that humanistic element, is that what prompted a pivot into academia and research?
Um, a little bit, yeah. I think, yeah, just again, well, I suppose a little bit, and I suppose it was another choice about not doing something. I everything I did is about not doing something.
Yeah.
I loved sharing knowledge. I knew I worked really well with students, sharing that knowledge, that love of learning new things. I knew that I didn't want to be a manager. I didn't want to lead the intensive care unit. And so management was so education and was a really important kind of choice, another route of the next another option, I suppose, and how I could make change, I suppose.
Yeah.
And yeah, yeah, yeah.
Excellent. And your current research endeavors focus on people living with obesity and how
Yeah.
they experience healthcare and how healthcare services are provided to those those people. What got you interested in that sort of thing?
Yeah, really interesting. It wasn't something that uh, I had always been interested in. I suppose it was, um, and how it came about again was being with people.
Mm.
And I was working in the public sector, and I was working in the private sector, and I started to notice differences in how services were being sort of offered. And just one patient, when you think about these pivotal moments in your career, and that kind of changes things. And I remember being with a person living in a bigger body, and she had was having weight loss surgery, and it was late at night, and I was talking to her, and she was talking about the struggles that she had been experiencing in the workplace, in her social life, and that she just wanted to fit in. And that's all I remember her saying, was she just wanted to fit in. And it had led to her remortgaging her home and paying to have weight loss surgery. And
Wow.
for whatever reason, that just really, really stuck with me. And I thought, this isn't right. There's something just not right here. And to this day, I still think about, I wonder whether she got the life that she wanted. I wonder whether the surgery gave her that life. And that really was the defining moment for me to start thinking about what services should be put in place. And so I started down my PhD, and I started to observe what was going on. I started to observe care practices, and my PhD, I spent 4 months observing doctors and nurses in the intensive care unit, providing care to people of larger size. And I started to see the way um, um, there was social awkwardness in care practices and how people were providing care, and the um, um, the the way that, the confronting way that we needed, I'm trying to think that kind of how confronting it was, that the social stigma that was in our care practices, and that we needed to challenge the stigma and the practices that we were all facing. And that really was the where all this work has been started, really.
Right. Yeah, that's really, really interesting. Why do you think health services are not geared to deliver? Well, why is healthcare set up in that the services are not delivered equitably to people with larger size versus those without larger size?
It's a really, really good question. I don't think we give it enough attention. I think that we spend a lot of time and energy and a lot of money looking to prevent obesity and manage obesity. So there's lots and lots of funding for the prevention and management of obesity. Um, my area is very niche, and we don't really know how to describe my area of practice, which is how do we provide care for people who come into hospital who aren't in weight management services, who aren't looking to be changed, who are coming into hospital for any other reason than weight loss. So they've had an acute illness, they've come in with COVID, they've got a respiratory problem, they've fallen over, they've fallen off the ladder and they've hurt themselves. How do we provide services and care for this group of people? We don't really have a name for it. We say it's bariatric care services. And so how do we provide a service for this group of people? So what's equitable? I've forgotten actually what your question was, to be honest. If you could remind me.
Yeah, I'm just
Yeah.
curious as to why the services that are delivered inequitably with patients or bariatric patients. Yeah, like the root
Yeah.
cause of it. Is it attitudes? Is it hesitancy to seek care? Is it difficulty managing patients of larger size?
Oh, there's lots of things, lots of things. And so the hospital services are set up for people of sort of normal sized bodies. And so um, we don't have the equipment, the service provision for people who live in a bigger body. That fundamentally is the problem. And so when we think about equity in terms of people who live in a larger body, the healthcare system is structurally stigmatizing. The practices are stigmatizing. So if we think about a person that comes into hospital, um, they come into the waiting room or the atrium of the hospital, and there's not a chair that's big enough for them to sit in. That's stigmatizing practices, whether it's intentional or not. That creates feelings of shame, embarrassment, and humiliation. So that causes issues for them wanting to access a healthcare system. There's, when they come into hospital, things like blood pressure cuffs aren't the right size, gowns don't fit. That's undignified care. The beds aren't the right size. So it's there. These are the sort of inequitable challenges, I suppose, with the health service. Um, the other kind of challenges is wheelchairs. There aren't enough wheelchairs to help transport patients coming into the hospital, or the wheelchairs don't actually fit into the public toilets or into the bathrooms and things like that. So patients can't use the facilities, the bathroom facilities and stuff, those sorts of things. So it's the fact that the hospitals, the health services are structurally stigmatizing. So these create feelings of shame, embarrassment, and humiliation for people of larger size. So these are the equitable issues that we have. Then we have funding issues. How do we pay for these services? Every patient, we go into hospital, there should be a bed for us, but there aren't the beds that are appropriately sized to fit for patients of larger size. Often there isn't even a chair. And so these are equitable service issues. So when we think then about, the thing that I'm really interested in is about patient experience, what's the experience for that person when they come into hospital? That's, if there's no bed or a chair, how does that affect their well-being, their psychological well-being when they come into hospital? Are they willing to come into hospital? So we have delayed access to hospital, and then we have delayed we have avoidance, and then when patients come into hospital, they're sicker when they actually arrive. So lots of inequities, and I could talk for hours and hours and hours about the inequitable practices. And so it's funding, comes down to funding.
Yeah, it's interesting. You also mentioned earlier about, it's not discussed or talked about. And I remember just when you said that, I was reminded of a conversation I had with my mother a few years ago. We were talking about, mental health concerns of younger people, millennials and Gen Z. And, she made a classic boomer type comment, which is, oh, back in my day, these things didn't exist. Are we making them? Are we fabricating these new things in the modern age? That's just normal variation, right? And it reminded me that, like, well, if you don't have the language for something, or if you don't openly talk about something, it essentially doesn't exist. So if you don't research and have, different people sharing their experience about a certain thing, like requesting or seeking health services as a person living with obesity, then that experience doesn't exist. So you can't address it.
And that was a fascinating thing out of my PhD, which was really confronting for the ICU community when I started presenting it, was that we didn't have a language to talk about care issues. And there was a couple of reasons for that. Is that we have a biomedical model of obesity, which is about prevention, risk, disease, and then there's a socio-political language of fat, oppression, stigma. And then over time, our biomedical language has been politicalized. And so we don't really know what language we should use. Should we say the person's obese? Should we say they're fat? Should we say they're morbidly obese? Some patients like to say fat. They're happy to be called fat. As health professionals, that's not a language that we are happy using, and so on and so on. And so then what I was seeing then in clinical practice when I was observing the care environment is that the best thing to do was say nothing. And so during handovers, when there were clinical issues, it was best to actually not describe anything. And so the health professional stood at the end of the bed and started to use secret language and euphemisms and started pointing at things. Well, the patient in the bed knew exactly what was going on. And so then it became this awkwardness, this social awkwardness. And then there was this mutual pretense that everyone knew the person was big, that no one said anything. And then we have this significant issue that we have no language, we don't know how to talk about it, and we've got this problem. And so I confronted the intensive care environment community with this challenge. And it was quite confronting. We were like, well, this is a real problem. And I said, well, we've got to do something about it. And there was a large person in the audience. And I was like, well, this could be challenging. And they came up to me afterwards and they said, thank you. We actually really, really need to have these conversations, and we need to really start naming it, talking about it, and actually confronting these issues, because we're not going to move forwards if we're all pretending that there's nothing to see here. And so that's
Yeah.
been a really important part of what I've been doing, and my teams have been doing, is actually we need to name it, we need to start talking about it, and we actually need to bring teams together who are able to start having open conversations about what the challenges are and naming the challenges.
Mm.
Whether we've got language right, we don't know yet. But actually, if we say nothing, that's a real problem. And so um, we need to make a start. Yeah.
Yeah. I remember having a discussion with someone who said, don't let perfection be the enemy of good, right? Just
Yeah.
because the
Yeah.
language might not be perfect doesn't mean you shouldn't adopt something to get the
Yeah.
conversation going and a framework in place to be able to address it or solve it or ameliorate
Yeah.
some of those
Yeah.
awful downstream impacts.
Yeah. And I use all different types of language. I use fat, obese, morbidly obese, people living in a bigger body, plus size. And I talk about it in a way to say, well, lots of people use different language. Now, my PhD, I honoured the patients in my study who said they wanted to be called fat. Now, when I presented that, the medical community were appalled and were really confronted that I described the patients as extremely fat. But I honoured the patients who said, please call me fat. In fact, the medical journals wouldn't publish the work initially, which was really interesting. And I had to refer to calling them morbidly obese, which was really offensive to the patients at the time. Now, language has moved on. This was published in 2015. Language has moved on, and we now refer to people as people living with obesity, or plus size people in the UK is a quite a popular phrase. And so, I feel quite passionate that we have to be open and say, look, language changes with audiences, with different people, different communities, but you have to start naming it, be out there, start talking about it, and have those types of conversations.
Right. So for people to understand the setting here,
Yeah.
how would you define a person as living with obesity? Is there a weight cutoff? Is it a BMI? Is it other biomedical or chemistry factors at play as well? Other health aspects?
Yeah, that's a really good question. And again, it depends what context you're working in. And so the World Health Organization has now described obesity as a chronic condition. It's a chronic relapsing condition, that is a long-term condition, that is excess adipose tissue, so excess fat, that leads to impaired health. It's caused by obesogenic environments, also psychosocial factors, and genetic variants. Often we use BMI as a sort of classification of defining someone who is bariatric, which is also morbidly obese. And that's body mass index, which again, there's two kinds of definitions, but in my work, that would be a body mass index of 40. And so that's pretty sort of standard description of someone who is classed as a bariatric patient. However, in my sort of working context and thinking about health services and the development of patient services and how we provide care and quality of care, we broaden that up a little bit more to being more than just the BMI of BMI 40. We actually add a weight. So it's someone who's more than 150 kgs. And that's because of the types of equipment we might use to support care. But also we broaden that even further and we think about someone whose physical dimensions, their body size impedes physical movement and also impacts on moving and handling activities. And that's because we want to incorporate the fact that people of larger size have limited mobility when they come into hospital and that they need the support of healthcare professionals. And so we're putting the healthcare staff into this definition of what a patient who is of larger size, a bariatric patient is. So it's a much broader definition.
Gotcha. So obviously, if you're that weight or that BMI, and by definition by the WHO, you need to have other health impacts because of your size. these kind of patients need to have access to healthcare services because they are more at risk than a person of normal size or a person of normal BMI. And yet the reverse is often true, that they have a hesitancy to seek healthcare because of the stigmatization or because of the negative, you know, or the poor care that is provided. So it's quite an interesting juxtaposition
Yeah.
or antagonism, right? I mean, people that
Yeah.
need it most don't get it based on, and I think people would say, well, they should be in a very negative perspective might be patients need to be incentivized to lose weight, but often that's a very tricky thing to achieve, right? I mean, like we've been fighting the war on obesity for decades and hasn't made it any better. No, it's just modern life is set up in a really way that is antithetical to
Yeah.
being of normal size for a lot of people. So you're not. So it's like just because you are trying to find ways to support the health services of these patients, you're not endorsing their lifestyle. You're not endorsing the way that they live their lives. But you still need to, from a humanistic perspective,
Mm.
provide them with the best care that they should be entitled to.
Yeah, absolutely. And so these services also incorporate, if patients came in for bariatric weight loss surgery, it's a wraparound service. It's a holistic service that we're providing.
Mm,
That's the point of the work that me and my team do, is how do we provide a service that provides appropriate care, that is, a high quality service that provides just the basic care, a bed that fits. That's not, we're not asking for specialist services here. A bed that fits, a chair. A chair is a really, really basic but important piece of equipment for recovery, for psychological well-being when you come into hospital. And without something like a chair, it actually increases your length of stay in hospital, because it's a really important part of the next step of mobilization to, moving it out of hospital and those sorts of things. It's part of your rehabilitation process. Gowns, being able to go to the toilet, dignity and those sorts of
mm,
things. These are really, really important factors to your well-being, your motivation to get well, and those sorts of things. So, they're basic. They're not fancy drugs, that are going to do amazing things to health outcomes. So these aren't health outcomes. These are healthcare outcomes that when we think about service delivery. So yeah,
yes.
yeah.
Yeah, that's really interesting. So, what you kind of touched on it already, but aside from what you've already mentioned, the downstream impacts of having poor healthcare services or
Mm.
healthcare service provision for these patients, I imagine it does take a toll on mental health, quality of life, future seeking of healthcare for issues. We
Mm.
mentioned that these patients are already at risk because of their size for other issues. So there is a real unmet need there if
Yeah,
patients aren't seeking healthcare or they aren't getting the healthcare that they need.
yeah, yeah.
And what about from the healthcare practitioner's side? What has your research uncovered there? Because obviously you would need to treat a patient living with obesity very differently from a normal sized patient. But I imagine if you don't have the language again for it, then you don't know how to approach it properly. And if you don't have the language, it doesn't exist, blah, 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 like we mentioned. Mm,
Yeah, so a lot of it is about education. Um, you know, uh, Healthcare professionals aren't immune to weight bias. Uh, there is so much literature around health professionals having weight bias. Also, health professionals who actually work in and support patients um, in weight management settings, so they specialize in weight management, also do have weight bias. So nobody is immune to weight bias. So so how do we manage that when we are providing care to people of larger size? So that is quite a confronting, part of for us as healthcare professionals, that we have to really kind of consider when we're thinking about how we engage with patients of larger size or people living with obesity. And so one of the things that is really important is ensuring that we do have the right equipment, we do have the right education, we do have the right provisions to provide the best care. And if we can do that, then we can also then, as part of that, address some of the weight bias issues, some of the address some of those sort of structural kind of stigmatizing practices that I talked about at the beginning. We take some of that away at the same time as addressing some of those weight bias issues that we also have in society. Then we can address some of that. But there's a lot of education that we do around how do we reposition patients appropriately, how do we use the equipment, and how do we keep ourselves safe when we move patients safely from the bed to the chair. A lot of the work and a lot of the education that needs to happen is around a person of larger size has how they move is very different. So how soft tissue moves, how soft tissue behaves, and how it is distributed around the body changes how that person moves and how they get positioned in the beds, in the chair. And that's one of the reasons, or can be one of the areas how a person gets injured, how a staff member can be injured. So a person's body can behave in an unpredictable way. I suppose that's one of the ways I'm maybe to explain it. I think I'm trying to think of a really good way to explain it. I think that's the kind of thing, is that where the body fat is distributed, and here we come back to that language issue. I think so, where the fat deposits are distributed in a person of larger size, and then how that soft tissue moves around the bed, or when you transferred from a bed to a chair, can be unpredictable and is different for each person. And so when we learn moving and handling, we need to have an understanding of how that soft tissue moves and how it can pull the sort of anatomy underneath that soft tissue. That's where the education is really important for our healthcare professionals. That's kind of a really important part. And choosing of equipment to match the anatomy, now that sort of different anatomy of that individual, that's the really important part of the education that needs to happen.
Right.
That makes sense.
So absolutely. So I mean,
Yeah.
you can't address a problem without first defining what the problem is,
Yeah.
developing the language around the problem to further define it. It's an iterative process. It's not just like your first definition. It's like, oh no, we need to. It's the language thing. It's how we approach it. So once you've defined the problem, you can come up with solutions. It sounds like the solution here, and again, this is about the humanistic approach. It's about the here and now for these patients, not the endorsement or lack thereof of their lifestyles, but it's about how we provide care. So it sounds like education is, you just said it, is critical here. It's education on the patient experience from our perspective of the healthcare practitioner, and it's education on how a healthcare practitioner can manage a patient of larger size. Would that be an accurate kind of summation?
Yeah, absolutely. This is all about education. It is absolutely about education. It's about understanding your own prejudice. It's about understanding how to go about caring for someone, understanding the perspectives of the other person, and both perspectives, actually. I think that's really important, is that the person of larger size already comes into the health environment with expectations of how they're going to be treated by the health professional, and therefore building a rapport, and that's critical. That's the starting point of the relationship. Before you actually provide any physical care, you have to bridge that gap, that social awkwardness that I was talking about a little while ago. That you have to break that social awkwardness. You have to build a really trusting relationship, because there's a lot of fear, there's a lot of mistrust, there's a lot of fear about whether the equipment is safe, and that's something that we, talk to healthcare professionals about, is actually reassuring the patient that that piece of equipment over there is safe. You will be okay on it. It is absolutely appropriate for your needs, because you don't know what experience that person has had before on a piece of equipment that was inappropriate, that kind of looked the same but actually wasn't, and they've had a really bad experience on that piece of equipment. And so it's about communication
Mm,
all the time. So building trust, communication, and how you portray yourself in that conversation is really, really important. And keeping a check always of your own conscious and unconscious biases, I think is really important.
so that's a quite a nice segue for us into
Yeah,
the project that you
yeah,
have now with Te Titoki Mataora, TTM, MedTech IQ, many different names that we can refer to them by.
yeah,
Because you've received some RAP1 support from them.
yeah.
Gosh, I forget what the acronym stands for. Maybe you can help me out here, Kaz.
Yes, yeah. So a RAP1 is Research Accelerator Program
There
Stage
we go.
One. Yeah,
Yeah,
yeah. So
yeah.
the Stage
To
One, yeah. Okay, so Stage One is it was about ideation. Yeah,
Yeah, so that's
yeah,
really putting together or getting the wheels turning for a potential educational and educational solution for these problems about provision of healthcare or the awareness of how healthcare is perceived from patients living with obesity.
yeah.
Yeah.
So the project. So again, so a couple of years ago, myself and Eleanor Barrett, who is the moving and handling specialist at Wellington Hospital, she looks at all of the reportable events, and she gets all of them around patient staff injuries. And there was quite a few that kept coming through around a weight being identified as causing staff injuries, musculoskeletal injuries. So basically, moving and handling injuries and weight have been identified as being an issue. So these were relating to people of larger size.
Right.
We also were noticing through the work that we were doing, being around the hospital, that um, staff um, in were trying to move patients in really cluttered spaces. And instead of moving equipment around, they just kind of were leaning over staff and things like that, which is, moving and handling nightmare. And we're like, well, what's going on here? Or not having enough staff, all these sorts of things. And we were like going, oh, this is a bit of a nightmare. I'd also been doing some work in aged residential care facilities, and we had measured all the facilities to see whether they were fit for purpose for people of larger size moving into residential care facilities. And we were like, wouldn't it be an awesome idea if we could create this VR kind of education package where we could manipulate the environment, we could do all these really cool things, and then just get people to use it. But then we were like, well, you're an occupational therapist, I'm a nurse, we've got no VR experience, so we parked the idea. And then Brian Robinson, who works in human resources, works here at Victoria University, also in simulation, started to do some VR work with some colleagues. And then we're like, oh, this is interesting. This is quite cool. We can kind of maybe pair up. And then along came Nadia Pantidi, who works in the School of Engineering and Innovation Design, who works in computer science. Started was introduced to us, and we are like, oh, okay, so now we're starting to build a bit of a team up here. This is quite exciting. And then Dale Luke, also from Wellington Hospital, is our multicultural advisor and also works in moving handling. And so we were like, actually, now I think we could have a project. And Brian also works for MedTech, or was on one of the committees. And he said, do you know what? I think this project, we should apply for RAP1 funding. And so this is how we started to build this idea of this team. And so we applied for some funding. And the really good thing about the RAP1 is, and like with many grants, often you have to try and find a team, get everyone together, do all the hard work, and then apply for a grant. Whereas this funding is about actually creating a team and doing the ideation as part of the
Mm.
actual grant. And so that's what's been really, really good about the Rep1 is that the money is about creating the team. And so we applied for the money, and the idea is that we started to reach out and create a much bigger team. And I think the team actually is about 20 people. And so that's pretty much what the team is about, is that we applied for the money to do two things. The first one is to create a team to to basically do the ideation, and then the second one, which we'll talk a bit more about in detail, the second one was to actually then think about, well, what would a prototype look like for a VR education platform that would look at a way to educate people about choices around patient size, about spatial design, considerations, equipment, and empathy. So how do we build
Mm.
in empathy when we're making these when we're moving people? So it's all about moving and handling. How do we, develop a moving and handling education package? So that was what the Rep1 was about. Yeah.
Yeah, I mean, I think it's really interesting how this the Rep1 supports that really early stage coming together of like-minded individuals
Yeah.
with an idea to actually get something going. Because, like you say, um, otherwise, without that, you would have to done that in isolation
Yeah.
in your own time, or maybe it was even impossible, and then the next stage wouldn't even be an
Yeah.
alternative, right?
Yeah.
Yeah.
Yeah. And so, yeah, and that's the thing. And so we spent a whole year building this most fabulous team. And our project changed. And so we were really narrow because I had me and Eleanor, and we were like, this is the problem. We've seen it over and over again. And we just wanted to really focus on this moving and handling problem. And so we had a hui, and we invited the hospital's co-chair of the patient advisory advocacy group, Dennis Moana, and a Pacifica community leader, Rosetta Stone Ilupelli. And they came along, and both of them are people living in a larger body. And it was phenomenal. We also invited Wellington Free Ambulance. They came along as part of the group, and then we invited lots of people from the hospital for their different perspectives of what it is like to care for people of larger size. So we brought a whole load of different people in, which again can be very confronting when you've got people who have been injured by people of larger size, and then you bring together people who are of larger size, and you come together and you have real frank, open conversations about these experiences. And you're talking about weight bias, you're talking about harm, you're talking about injury. Patients also talked about being injured as well. So, there was a lot of, conversations. But what was really good about this team is that every single person that came really came because they'd had a real personal experience and they wanted to make change. Um, and so what we went from being such a narrow focused project actually became something that was about being in the home and the challenges of being in the home and needing to go into hospital. And so that was really good because we had Wellington Free Ambulance. Um, and how does Wellington Free Ambulance navigate the challenges of taking someone from home and into the hospital system? And then the whole, what we've talked about a lot, being in hospital and then going home again, or wherever they need to go, whether that's a hospice, or even actually if someone dies. We haven't even touched on what happens when someone dies, and the whole challenges around the funeral homes and things like that. And so this became now a journey through, and moving and handling is just part of that. And empathy became the key focus that we wanted to kind of have as the thread through. And cultural safety was also a really significant part. So I think this has been what's been so exciting, is that it's now about much more than just the small idea that me and Eleanor had from what we'd seen in practice. Yeah.
Yeah. So ultimately, where do you see this project going? So it would be
Yeah.
rolling out this VR solution, educational solution, empathy promoting solution to all the different, stakeholders along the value chain,
Yeah.
essentially, that are providing care.
Yeah,
And
yeah, absolutely, absolutely. So we've got a RAP2, so that's really exciting.
yep,
So,
great.
yeah, we've just been awarded a RAP2, which is um, about it's a seeding grant, and so now we are developing and going to test the prototype that we're going to build. And then what we've done is we're going to test in 3 different groups. So we've got now as our research partners, we've got Fitteray in New Zealand, and they are working as part of the group to look at testing it in undergraduate, so pre-registration healthcare professionals, which is a really important part of looking at developing education and training um, in um, in healthcare professionals. So right at the beginning, before they go out into the workforce, ensuring that this education is embedded in their practice. And so we're looking at testing the system in the pre-registration health professional group. So nursing students, Pacifica and Māori nursing students, and in paramedic training. Then we're looking at the health professional group, and then Wellington Free Ambulance are taking on that testing and usability. And then the next group that we're really interested in is we're working with Essential Healthcare, which are equipment suppliers of bariatric equipment, to see how it could be used in education of when services are being implemented within hospital systems. And so equipment suppliers often provide the education when services are being rolled out. So we thought this would be a really, really good way to see how it could be used. So ultimately, how is it going to be used? Well, we think it could be used all across the healthcare system in multiple different ways. Yeah,
Yeah.
I
And
think it'll be
then,
used.
well, I mean, again,
Yeah,
if you're using it across the whole spectrum of the healthcare system and everyone
yeah,
has that understanding, has the language, has the empathy, you can actually address the root problem, which is
yeah,
inequitable healthcare services,
yeah,
right? Yeah. I mean, that's the
yeah.
goal.
Yeah, absolutely, absolutely. Yeah, just everyone, wherever you are in healthcare, gets a little bit of this education somewhere in your workplace. Yeah,
Yeah.
yeah,
Excellent. Well, that's super, super interesting. I mean, I
yeah,
can't say that I've really given, this kind of. I mean, I'm probably one of the people that really needs the the VR project
yeah,
solution here because I haven't given it a second thought. Really,
yeah,
I'm not. I'm a bit ashamed to say that, but it's really interesting because we need people such as yourself that have these insights, that notice that there is an unmet need, that notice there are downstream issues because of this unmet need, and can work with a place like Te Titoki Mataora
yeah,
to provide the research funding to actually make a solution for it. I think it's really great little ecosystem that is
yeah,
happening here, and it's exciting that the funding has been made available for the ideation, the
yeah,
conceptualization, and then in the future the rollout's really cool.
yeah. Awesome.
So if people want to find out more about yourself or the project, Kaz, where can they go?
Oh, okay. So, well, I work at the university, so really it's looking on the university website. So that's the best place to kind of find out about me. Um, I think if you want to find out about the project, it's going to MedTech and having a look there. There's stuff on the MedTech. There is a conference in June, so there's lots of promotion about the conference there. I'm presenting about the RAP1, about the reciprocity of the project, the recognition of the project, and how equity is really important in technology. So yeah, lots of things happening, and basically just watch this space, and I think that's probably the best way to find out about it. Yeah.
Awesome. All right. Well, I'll see you at Health Tech Week because I'll be there too.
Oh, brilliant.
We see you in person. Yeah.
Yes, be good.
Excellent. Well, thank you so much, Kaz.
Oh,
This has been really, really insightful and interesting. And
excellent.
all the
Thank you.
best with this project and the future ones down the pipeline. And
Excellent.
yeah, really appreciate your time.
Awesome. Thank you very much. It's lovely talking to you.